Ulrich Sidney Kamunye. I'm the President of the Association of Future African Neurosurgeons. Today we have a monthly journal club. We're going to discuss a very interesting article that is dual antiplatelet therapy in stroke and ICAS. So before we go ahead, we'll do our customary presentations of all the panelists. Let's start with Darwin Sichimba.
Hello everyone, my name is Darwin Sichimba. I'm a student at Copperbelt University and I'm a member of the research team, research department of the Association of Future African Neurosurgeons. I'm happy to be here. Thank you so much.
Thank you, Darwin. Next up, Lorraine Sebopelo.
Hello everyone, I'm Lorraine Sebopelo, a third-year medical student from the University of Botswana, and I'm glad to be here. Thank you.
Thank you, Lorraine. Next up, we have Samuel Chilawa. Samuel, if you're speaking, you're muted, so we can hear you. So you have to unmute. Yes, go ahead, Samuel.
Hello, everyone. My name is Samuel Chilawa. I'm a fourth-year medical student at Copperbelt University, and I'm a member of AFAN as well. It's good to be here.
Okay. Thank you, Samuel. Next up, Zolo Ivan.
Hello, everyone. My name is Zolo Ivan. I'm a CTA medical student from the University of Buea in Cameroon, and also the head of communication and operation unit in AFAN. It's a pleasure and honor to be here today.
Thank you, Zolo. And last but not the least, Olorintoba Ogunfolaji.
Hello, everyone. I am Toba Ogunfolaji. I am a final year medical student of the University of Ibadan. I'm happy to be here. Thank you.
Thank you. So now we're going to go ahead. I'll be sharing my screen so that everyone can see. I hope we all got the chance to read the article. I think it will make for a much better conversation if we've all gotten the chance to read the article. Obviously, I'll make sure to facilitate understanding of this here, but please feel free to come to ask questions. So I think before we go ahead, perhaps, did anyone have questions after reading these articles? Is there anything you didn't understand or you felt was difficult? If yes, you can either raise your hand or you can send a message in the chat box. So if we're not getting any hands, if we're not seeing any hands raised, I guess everyone pretty much understood what was said here. Is that the case? This is your opportunity. You shouldn't feel in any way intimidated by this. This is your opportunity to ask the questions. I mean, our objective here is to get each and every one of you to be able to participate in such a research tomorrow, not only design it, but lead it. And equally that without us, you should be able to read an article and make the most out of it. Okay, so I just hope that, I have to be frank here, I just hope that you're maybe shy, and I really hope that it's not that you didn't read the article, because if you didn't read the article, then this session will not be very helpful for you. And you have to think about it this way. If in fact you didn't read the article before attending, you should know that these are the kind of attitudes that will get you to go to the OR with the patient without reading up on the disease. And that's not good. And no matter how much you feel you are busy, you need to be able to, it's not about making time, it's about being more organized. So if you're in a situation where you didn't read the article before the journal club, then you won't get the most out of it. Obviously, I'll do my best to explain stuff, but I say this because I've had so many questions come from our members on things that we've explained before, things that we've spoken about, or things that are already available. I don't mind answering those questions, but I think you need to think critically about what it means to be a neurosurgeon. Okay, so what it means to be a neurosurgeon is you need to always be prepared. You need to always prepare what you're going to do. Always, always, always. You need to review it. It doesn't take much. If you went through the article and it felt challenging, then you have it's only fair to ask those questions. That's why I'm here. That's why we're taking this time to make sure that we're answering your questions. So anyway, if you feel like there's anything you didn't understand, please feel free to stop us at any time. during the session. And obviously, like I said, you need to look at this. One of our biggest weaknesses at the moment in the group that I've noticed is with academic writing. I shared some documents with everyone to make sure that we improve academic writing. Usually, we have difficulties expressing our ideas succinctly. So when you go through this kind of articles, look at the way they write things and ask yourself, will I have written it this way? And what is different? And obviously go back to those other documents that I shared with you to make sure that you make the most out of it. Personally, I think anyone who's read this study will have a lot of questions because immediately as you start with the study, you see a lot of acronyms. Okay, so first things first, when you start with a study, you start seeing things like ICAS, you see things like chance, you see things like Ishua, UCAS, all those things. Like, so this was definitely an article that would get you to read a lot. And if you're interested in anything neurovascular, then you want to know what these acronyms mean, what were their key findings, and how they were carried, how they were done, what were their limitations. So very important, in fact, very important. Okay, so let's go ahead. Anyone care to give us a summary of what this article was about?
Okay. I think from what I read, I mean, the article was trying to evaluate two modalities for treatment, if you can say like that, like using aspirin and other I mean aspirin plus other modalities like clopidogrel, using it in patients who have some basic or some baseline intravascular problems, and comparing the results with those that do not have intravascular baseline pathology, if I can put it like that. So some studies were done before, and some observations were made which revealed that aspirin could be helpful to reduce the risk or the future neurovascular, I mean, yes, future events of some endovascular accidents or problems. And they tried to, but there was no, how can I put it, there was no comprehensive or some sort of, there was no evidence that combining aspirin to another drug could actually benefit patients who have some sort of underlying problem. So this study was being done to point out, also try to bring out that evidence, if any, exists.
Yeah, you've covered a lot of what the article is about. There are a few things though that are not that were not exactly placed the way they were. So it's clear that you went through the article. So now what we're going to try to do is try and make sense of it from a neurosurgical point of view or neurological point of view, as well as on the other side from a research methodology point of view. So thank you for that. So my question would be, it's really simple. So what kind of research design was, what kind of methodology did they use to do these comparisons that Zolo just described? This has to be interactive. So feel free, if it's not, you don't have a noisy background, to answer.
Hello?
Yes, Gideon, go ahead.
Oh, great. So yeah, just off the back of what whoever spoke before said, I think it's comparing two different groups. So with two specific treatments. So if I'm not wrong, it's a prospective cross-sectional study. I don't know if it's cross-sectional because it's comparing two treatments, but I remember it was definitely prospective, from what I remember.
Right. So what we had here was we had two groups. First, let's get to the background before going to get to the methodology and understand what happened. So initially there was a study called Chance, right? This study came out of China, was multi-centric. And first of all, what we need to all understand is that our authors in this case decided to, let me share the screen just so that everyone is on. So our authors in this case decided to do an analysis of a subgroup within chance. So first, let's put that into perspective. And the rationale here was they had some findings that were discordant with other publications. So a lot of publications out of the Western world, were like, so here the question was, okay, aspirin alone versus aspirin versus and clopidogrel. They did have some a double dummy kind of design where they had placebos. So the first thing that we see here is this effects, right? Effects of clopidogrel plus aspirin versus aspirin alone in reducing the risk of any stroke recurrence. So that is what we're trying to evaluate here. And like I said, if you're going to study anything neurovascular, if you're going to try and understand the outcomes, there's some very famous studies that you need to know, and they did a great job in the introduction, laying the ground for that. Then the question now becomes, like we always ask when we're in introduction, do you think that this study question is relevant? So do you think, I'll ask other, so is it relevant? Is it clear? Do you think this is a study that was worth doing?
Yes, personally, yes, I think it's relevant because it follows the final criteria, the feasibility, interest, novelty, and relevance. So I think the question was relevant.
Okay, great. Exactly for what we said before. Great. So now the next question becomes, coming back to what Gideon said about the methodology that was used. It was definitely prospective, definitely. Now, what do we understand by cross-sectional? In cross-sectional, if you remember, we have three big types of study design, right? We have, we'll start in observational studies. We have three big types of study design, sorry. So we have cross-sectional, we have cohort, right? Or above and between the two, we have case control studies. Now in a cross-sectional, you're going back in information. So with cross-sectional, you usually go back to get information. So it would be really difficult to have like a prospective cross-sectional, because cross-sectional is a snapshot, right? It's a snapshot of an event. And often you just go into registries, patient registry, patient data to get information. Now, in terms of hierarchy of evidence, we all know that in terms of research design, at the top of the top, we have those systematic reviews and meta-analysis that are used to get guidelines. Below that, we have randomized controlled trials, and then we have those observational studies. In between, we can get quasi-experimental. If you remember, we had a talk about this before, I think 2 or 3 months ago. Now, what kind of study designs did they have here? You have it here, just so it tells you just right here. It was the first word that you see here, random allocation. So it really sends you towards a direction, right? RCTs. It was double blinded. It was double dummy, right? So what do all these words mean? When we say random allocation, if you remember again, when we spoke about RCTs, the big plus of RCTs is when you do a really random allocation of your patients, what happens is the comorbidities are equally distributed in each group. And so all that you're studying is your intervention and seeing what relationship between your interventions and your outcome. So when you do that, now your conclusion is not just one of association, it's one of cause and effect, because you've made sure that all confounders, all other things that could explain some kind of modification are evenly distributed in both groups, right? So that is what we understand here by randomly. That's the first thing. So we're going to be examining cause and effect. I mentioned the word interventions. Now, what are the interventions in this study?
Aspirin and clopidogrel, I think.
Yes, so in one arm, we had aspirin and clopidogrel, and in the other arm, we had aspirin alone, right? Now, those are interventions. So that's what we need to see. Aspirin in one group alone, and the other one is aspirin and clopidogrel. Now, as it said here, clopidogrel plus aspirin and placebo plus aspirin. Now, what do we understand by when we say double blind, when we speak about blinding? So again, we spoke about this before. You can blind so many participants or participants. You can blind a lot of actors in a study. You can blind the researchers, you can blind the statisticians, you can blind the patients. And so it's not usually, for those who do research methodology, they don't find it enough for you to just say double blind. But generally, when we say double blind, what we understand is that the patients are blinded, so they don't know what they're receiving, as well as the researchers. The researchers are blinded as well. Now, the fact that you haven't told the researchers what groups or which group is which is not enough. One quick example is you might not tell them, but you know, if researchers know that, oh, clopidogrel has this very specific side effect, so if they see that side effect occur very often in a certain group A, they might be like, oh, this is probably the aspirin plus clopidogrel group. So during the study, they might be able to guess and understand which group it is, and that in itself could be a failure, right? So so blinding, there's a lot that goes around blinding. It's not just we didn't tell them. That's not all it means. So that is very important to consider. Now, when we say double dummy design, here what we do with dummies is basically we have the placebos, and we make sure that the placebos, this is especially important in the case where you have, for example, two drugs, but they don't look alike, right? So say you have one that the drug is usually oblong, and then the other one where it's like quadrilateral. So it's difficult in that case to truly randomize. Just by the way the drug looks, someone can guess what drug it is. So in that case, what happens is you could get a placebo that's oblong as well as a placebo that is a quadrilateral, for example, and then you mix and match in such a way that both groups will have one oblong drug and one quadrilateral. And now in some cases it will be a placebo, in the other case it will be one of the drugs you're testing. So that is what we mean by double dummy. And so this is when you're reading the article, right? This is how you need to go through them. You need to ask yourself those questions. What do they mean here? Why is it important? How does that affect the way I will interpret the results, right? So that is what it means here. Another thing we want to ask before we go forward is, okay, we are in an RCT. Now, are we meeting those criteria for RCTs? So what are the things that are important? You need to anticipate on those. So whether when you're reading, you're looking for those for that kind of information. One of the easiest things is, was there protocol before the RCTs? Nowadays, it's almost impossible to have an RCT without a protocol, but it's always good. And if you can find a protocol, it's not a bad idea to go and read through the protocol to see if there were modifications to the protocol as from the beginning to the end, and if they were justified as well. So you want to check all those different information so that you see what the methodology says here and what the methodology what is said in the beginning. Imagine they had one endpoint in the beginning and then they change it in the end. You know, that raises a lot of questions. So it's always a good idea to look for those. There's a registry for protocols, and I think they even share the information for where you can find a protocol here. Now, the next thing is, while I'm going ahead, so if you have questions, please raise your hand or send a message in the chat box. We want this to really be interactive. Now, when you're in an RCT, besides asking the question, is there blinding? Was it really a random allocation? You equally want to know, well, in this study, how were the different groups distributed? It's always important to try as much as possible to get, obviously you calculate the sample size, but to get almost equal groups. If you're not getting equal groups, you can get like a ratio, maybe 2-to-1 or anything, but try and get those numbers. Yes, Lorraine, please go ahead.
Oh, okay. I wanted to know if, is it possible to have a statistically non-significant, like if there's no statistical significance, but there is clinical
Yeah. Yes, absolutely.
Significance.
Yes.
If it's
Yes.
possible,
Yes,
which one
definitely.
is more feasible?
No. You can have a mix and
Okay.
match of all of them. You can have a case where it is both statistically and clinically relevant or significant. You can have a case where it's not statistically significant, but it is clinically significant. You can have a case where it is statistically significant, but it's not clinically significant. So about your question, just a simple example, taking our case, right? Let's say we are calculating odds ratio, right? That gives us an idea of a risk, be it the odds ratio, the relative risk, or absolute risk. And when you interpret the odds rate, when you find your odds ratio, usually you describe the value of the odds ratio and the 95% confidence interval, right? And then from that you know whether it is relevant or not. Now, imagine that your odds ratio is like hundreds, in the hundreds. It's maybe from 100. The lower limit of your 95% confidence interval is 100. The higher limit is something like 2,000. Okay, and it is because it's between 100 and 2,000. It will be not only statistically significant, but it will equally be clinically significant because 100 means 100 times. That's a lot. Okay, that is a lot of probability. How do you know that is statistically significant? I think we spoke about this last time. Let me get back to this. Anything that is a risk, okay, is a risk are calculated as proportions, right? So just think about a fraction. A fraction has a numerator and a denominator. If the numerator is equal to the denominator, then the value is 1, okay? So when you're comparing two groups, if you divide the two groups, the value is 1. Just keep it in mind. I know it might be confusing in the beginning, but we'll get there. And if you get a value less than 1, then definitely the denominator is bigger than the numerator, okay? If you get anything less than 1, a fraction, then the denominator is larger than the numerator. If you get anything greater than 1, then definitely the numerator is greater than the denominator. So what you're doing is comparing two groups. In this study, we have two groups, right? We have one group, aspirin plus clopidogrel. Another group, we have aspirin alone. Okay, let's say we compare denominator. So below, we have aspirin plus clopidogrel. Above, numerator, we have aspirin. And if I tell you a risk, whatever the risk, if I tell you the risk is equal to 1, that means both groups are equal. They have equal values. It doesn't matter what value it is. So if I tell you, for example, odds ratio equal to 1, then both groups are equal. There's no difference. If I tell you that the risk is less than 1, then you understand that the group below, denominator, aspirin plus clopidogrel, has a larger value, a larger probability than the group above, which is aspirin alone. So that value will be less than 1. And now if the value is greater than 1, then you understand that the group above, which is aspirin, will have a larger value than the group below. How does that translate? Let's take this here. HR here means hazard ratio. Please remind me later on to explain what the hazard ratio is. Let's just speak about ratio, okay? It's a risk, some kind of risk probability here. So when I look at this value here, I don't need the p-value. I do not need the p-value. Why? I can tell you here that this is not significant, although there's a p-value here. Why do I know that? Because these values are on both sides of the figure 1. So that you have not only a value, the 95% confidence interval here is less than 1, and the 95% confidence interval here is greater than 1. It's on both sides of 1. So what that means literally is the lowest hazard value tells you that the denominator is greater than the numerator, and the highest hazard value tells you that the numerator is greater than the denominator. So they don't agree, they don't go in the same direction. So on one day, it could be that one group is better or is at a greater risk, or another day it's another one, and some days they are equal. So just for that reason, this here is not interesting in terms of statistical significance. Now, in terms of clinical significance, let's think about this. You're in front of a patient, okay? And what this is saying is the least possible hazard ratio, 0.57, but the highest is up to 14.1. So this is a lot for one individual to consider. Up to 14 times That's a lot. So it is clinically significant, although it is not statistically significant. Okay? Statistically significant just means that it is highly unlikely. It is highly unlikely that this difference actually exists. But for one person to consider as an individual, that is a lot. So you need to speak with them about the risk. But when you look at the spread of this 95% confidence interval, once again, let's look at that. It is less than 1. It is greater than 1. So it's on both sides of 1. So definitely the p-value here is going to be, it's not going to be statistically significant. But what is interesting here, look at that. 0.35, but look at the bigger value, 2.97. This, in terms of magnitude, this is a lot less than here, where it was between 0.5 and 14. So between 0.5 times and 14 times, and between 0.35 times and 2.9 times. So this, for example, this alone would be clinically interesting. You have to mention it to the patient. You have to speak about it, or you have to consider when you're taking a decision. This is clinically relevant, but not statistically relevant. Does that make sense? If you're confused, you let me know. We can try to make it a lot less complicated.
Yes, Doc. If possible, if you can just take it over. You go take
Okay. Yes, no worries, no worries. I think, okay, the best way to go about this is to take real life examples so that we don't just speak about numbers and it's just numbers all over the place. Let's use this case, okay? Let's go back up. Let's take method step by step, and I will break it down so that we're all on the same page. And please, don't let me keep speaking. You just get confused. Just raise hands so that the more I see hands raised, the more I know I'm losing people, okay? Let's take the methods first. Primary question. Let's try and understand the primary question. Very simple question, okay? We're trying to compare clopidogrel plus aspirin versus aspirin. So those are our two groups. From now on, all of us here will refer to clopidogrel plus aspirin as group B, and all of us here will refer to aspirin as group A, okay? Let's keep that in mind. I took group A for aspirin because aspirin A, okay? Just aspirin. Group B, something added to it, aspirin plus clopidogrel, okay? So those are the two groups we're comparing. And we're trying to reduce the incidence of a recurrence of stroke, no matter the kind of stroke. That's the first thing they defined here. They said, be it ischemic or hemorrhagic. Here it is. Here, that's what they said here. Effects of clopidogrel plus aspirin alone on reducing a 90-day risk of any stroke, be it ischemic or hemorrhagic. Okay. So comparing two groups, primary outcome, is there a stroke, yes or no? Okay. Now, yes or no, because that's how you answer the question. This is very important in how we're going to go ahead. So the event we're looking for within the 90 days of treating the patient is there a stroke? Yes or no? That is a binary outcome, okay? When you have binary outcomes, what you do is you express values in terms of probabilities. What that means is, so let's say you can say whenever you have no, you put a 0. Whenever you have a yes, you put 1. Okay. If we have 10 patients, okay, and 7 of them have a stroke, so yes, so 7 yes, that's 7 times 1, that's 7. And 3 of them have no stroke, so we have 7 plus 0 divided by 10, right? So that gives us 0.7. That 0.7, if whenever you're given that value, you need to understand immediately in binary outcomes, that means whatever the event was, whatever yes was, it happened 7 out of 10 times. Okay? First of all, keep it in mind. Why do you need to keep it in mind? The first time we spoke about statistics, we said this. You can have continuous variables. You can have binary variables or outcomes. You can have outcomes that are categorical. Categorical, for example, there are many groups, okay? They can be ordinal or nominal. Ordinal, as the word says, there's some kind of order. If I told you, take the grades of students at the A levels. The A levels, you have A, right? You have B, you have C, and then you can add, A plus or A minus or whatever. So that way you can grade students, and there's some order. There's no way someone can tell you that someone who had an A plus is less than someone who had a B minus. Okay, so there's order there. Now, we can have categories that are nominal. They have names. but they don't have any order. There's no order to them. If I gave you races, is there a way to put some kind of order in races? No. You just say, you wouldn't say this race is better or less than this other race. They are just races. That's it. So that is an example of a nominal variable. Now, if we take continuous variables, think about height, think about weight. You know, someone can have 70, 73.9, 89, 110, 120 figures, continuous. It just keeps going. Okay. And then you can have binary outcomes. Binary outcomes, the more common is yes or no. Did this patient have a stroke within the first 90 days? Yes or no. That is binary. So we ask a question about an event and we answer whether yes or no. If it's a yes, you code it generally as 1. If it's a no, you code it generally as 0. And then that way, when you will sum all the 1s and 0s, you will get a proportion. That proportion will give you an idea of the distribution of the event in the population. So put that aside. Now the problem is when you have a binary outcome with time, all you know is this is how many times this event happened, but you cannot tell how many times this event happens per unit time. So you've just taken a sum of events. How do you call this? You know, when I said yes and no's, and then the yes were coded as 1s, and then you add everything. That's like when you say the incidence of a disease. You say the incidence of a disease, so the number of new cases equal to this number of new cases in, you know, in this population. That's all you've done. You've only given the number of cases in a population. When you decide to consider time, when you decide, for example, to say, hey, we received 300 new cases, okay, and one person says, we received 300 new cases in 1 month. Another person says, we received 300 new cases in 1 year. You agree with me that those two values, although they are 300 new cases, are not the same thing. You need to factor time in. So once you start factoring time in, the kind of analysis that you're going to do is what we call a time to event. What is the event here? Stroke. What is the time within the first 90 days? A time to event. Okay? So we're going to do a time to event analysis. And last time we spoke about time to event analysis, we said that when we do a time to event, we do things like survival curves, you know, Kaplan-Meier curves. And if we're doing a regression, we'll do a Cox proportional regression, a Cox regression. We can calculate things like hazard ratios. So the hazard ratio is almost like an incident rate. Whenever you add rate to something, you're talking about time, something per time, right? So, and the hazard ratio is sort of an incident rate. It's telling us the number of times the events occurred per unit time. We've spoken a lot of statistics. What does that mean here? It means here that whenever we're calculating the hazard ratio, what was our event? Stroke, hemorrhagic, or ischemic. What was our time within the first 90 days? We're trying to see, okay, within these first 90 days, after 1 day, how many cases? After 2 days, how many cases? After 3 days, after 4. If we only say the number of cases in the first 90 days, we're just giving a global, you know, an incidence. But if we start saying on day 3, how many people had strokes? On day 4, how many? On day 90, how many? We're now thinking about hazard ratio. Does that make sense?
Yes.
Yes, it does.
Okay. I'm glad you understood it. Now let's go to the next step. Because remember how we got the incidence from the get-go, or the event. We said when the event happens, yes equals 1. When the event doesn't happen, yes equals 0. So let me put it this way. On day 1, we have 100 patients. Let's call it day 0 first. Day 0, we have 100 patients. Please follow with me. If we have 100 patients, and on the first day, 1 person has a stroke, the other 99 do not have a stroke. So what we will have is 99, no stroke. So 99 times 0, that's 0, okay? And only 1 stroke, that is plus 1. So we have 1 on 100. So on day 1, we have 0.01. Okay. Now, if we're going to calculate the same value for day 2, remember, we already had one person have a stroke. So on day 2, we don't have 100 patients anymore. We now have 99 patients, okay? So now if on day 2, we have 99 patients and 3 of them have a stroke, then we have 96 no stroke, so that's 0, 3 stroke, that's 3. So 3 on 99, that is what? 1 on 33, okay? So you do that calculation till the end, to day 90. That's what you do. And each time when you're calculating sort of an incidence rate for each day, you are able to give a value for a hazard ratio. So why is it important? It is important because it's going to not only tell us that, yes, this drug is working. Yes, this drug is working. A drug that works, or a group that has a good treatment, it will be like, we have a lesser incidence than the other group. But what we equally would like to know is, which are those days during which the patients are at a higher risk. So here we can tell you at the end of the day that, from day 0 to day 90, we noticed that patients were at risk of a rebleed between maybe day 10 and day 20. I hope you agree with me that is very important, to not only know which treatment works, but to equally know when we should be careful, when we should be worried about the event happening. What do you think? Is it important or not?
Yes, it is.
Okay. So that is why it's important here. Now, remember we're doing proportions, right? We said what? Numerator over denominator each time we're trying to compare. And that is how we had things like one patient had a stroke on day 1, and out of 100, we had 0.01. Now, when we calculate this hazard ratio, what we get is a value, a single value. And then we compute what we call the 95% confidence interval. So this is what you find here is the 95% confidence interval. So, and you can interpret whatever is a proportion without even knowing the p-value when you have the confidence interval, when it is a proportion, so long as the values are on both sides of the figure 1, then the p-value is not significant. But if both values are on one side alone, that is, they are either less than 1 or greater than 1, then the p-value would definitely be significant. So when we look here, we see 0.47, 1.32. We can see that within these figures, we can find 1. So here, the p-value necessarily will not be significant. That is what we call statistical significance. But when we look at this about Lorentz question, so this is 0.47, about 0.5, 1.3, meh. But when you look at this, between 0.57 and 14 is a lot. 14 is a very big difference. It's a lot. So clinically, you have to think about it. It might not be statistically significant, but it is definitely clinically significant. Okay. Now you give it more attention. Obviously, if it is statistically significant, you give it less attention if it's not, but you have to think about it. I will get to how we think about it later on. Now, so what is interesting as well here is, let's try and see how they defined their primary outcomes, their secondary outcomes. Really interesting. Look at the methodology. You can literally reproduce the study because they've taken the time. They told you. They always define what you mean. When you say, okay, hemorrhagic stroke, ischemic stroke, it's good to say it, but how do you define it? Is it neuroimaging? Is it clinically? Are you using a predictive score? What are you doing? And you see here that they really took the time to define all the events and outcomes. Here you have all those different words here. You have even information about eligibility. So really interesting. Now, getting to this here, one of the things they wanted to know is, one of the things they said they're going to divide 2 groups in what they call ICAS. intracerebral artery stenosis at the level of cerebral vessels. And here they tell you how they define that. You know, they had two neuroradiologists look at the images, and then they check if they both agreed on the level of stenosis, and they even give you information about their level of inter-rater reliability. What inter-rater reliability means is we look at first neuroradiologist, second neuroradiologist, you give them the same images, and then you see how many times they agree, how many times they have the same diagnosis and the same level of stenosis. And then intra-rater reliability, you give it to the same person, you know, the same kind of cases, and then see how many times they say the same thing. So that is what it means to have intra and inter-rater reliability. Because if they didn't do this, imagine they had a single radiologist, you know, that brings up a lot of uncertainty. And whenever you have a lot of uncertainty, it brings up questions about bias. Please feel free to ask questions. Please do.
Ari,
Yes.
I have a question.
Go ahead.
Does the fact that in this randomized control trial, they were talking about, they took into account only 45 of the different centers that the chance to, like 45 out of 100, and I think it was 19 or something like that. Would there not be a bias on their conclusion?
It's more than enough. 45 out of 100, and it's more than enough. You know, you need to think about even feasibility. Do you really think that it is feasible to enroll? I mean, enrolling 45 centers alone, that is a feat. That is a feat, a big major feat. So why is it, your question basically is asking when is sampling well done? When is a sample size appropriate? Remember why we do studies. We do studies because more than often we're not able to get the population, the target population. You can't round up the target population. So what you do is you try as much as possible to get a group of people that look like the target population. And that's why first you need to define what is your sample. First define what your sample is. They did that very well. They said who the sample was. And then the next thing they did was they calculated the sample size, and they met their sample size. So as soon as you meet your sample size, and as soon as your sample has the definition that your sample size has, that your target population has, I mean, you can't ask more than that. Adding more people to, or more centers of people, will not modify the results dramatically. It's going to add something, but not a lot. What does that mean? If you're looking at the 95% confidence interval is at what we call you take the mean, okay, plus or minus 2 times the standard deviation. Now, if you try to get the mean plus or minus 3 times the standard deviation, which goes around 99%, so moving from 95% to 99, to get only the equivalent of just like 4% increase, you would find yourself adding thousands of patients. In terms of time, money, resources, it's not worth it. 95% is more than enough. So you need to know when to say no. I hope that answers your question.
Okay.
Yes, Gideon, adding more people adds to sampling power. But what you need to consider is you have, when you're calculating your sample size, okay, on the one hand, you have to think about the alpha. On the other hand, you have to think about the beta, okay? Now, when you're going to determine what your alpha helps you with is with your level of confidence or your threshold for your p-value. So that in itself is interesting. The next thing is you need to think about, like you said, your power. When you increase power, then you're able to detect minimal changes. So that in itself, again, increasing is actually interesting. But what you equally need to consider is what is the epidemiology of the event you're trying to diagnose? How frequent is it in the population? And what is the level of clinical significance that you're trying to perceive? you need to be able to say this is enough to get the information we're trying to get. One, why? One, because it's a waste of resources to just add people. So just adding people is a waste of resources, so that's not justified. And the next thing is ethics. You cannot expose certain patients to a risk if the added risk, the added value to the study is not proven. If you've calculated a sample size and it tells you that you need 1,000, why go and get 2,000 patients and expose an extra 1,000 patients to get information that 1,000 would give you? So all those things have to be taken into consideration. When you're designing your study, always think about the statistical value, the clinical value, the ethical value, always. And in this case, you cannot say there's no risk for the patients. If you're putting the patients on aspirin alone, aspirin has risks. So it has to be justified. When you're going to an IRB, though, you understand this risk and that you've minimized this risk as much as possible.
Hey, is there any other question? No one? So for those who might not understand what Gideon was referring to when we're talking about power, power is like, so if you remember, if you go back to the video we did, just go back to the AFAN channel, you'll find a video, and I showed the 2x2 table. In the 2x2 table, we found we showed not only where the alpha was, what it meant, and the beta. And the beta gives you an idea on the power. Generally, the power is equal to 80%. It's interesting to increase it, but beyond a certain point, I mean, you just lose on other aspects of the study. So you have to get a good balance. Yes, Lorraine, please go ahead and ask your question.
Okay, so I just wanted to make sure that I understood what was being said. When they said that there is no statistical significance, does that mean that the results that could have occurred during the study might have occurred by chance? And if that's the case, that means that there's not much difference in the two treatments, like
No.
when it comes to, okay.
So you, all that you said till the moment you said there's not much difference, all that you said was right. The fact that the treatment,
okay.
the fact that a comparison is not statistically significant does not mean there's no difference. No, it just means that like you said, it just means that the difference that you noticed could have occurred by chance. And what do we call by difference? What do you mean by difference?
Okay.
In terms of hazard ratio, we said that if the two events are the same, then the hazard ratio should be equal to 1. Whenever the hazard ratio is not equal to 1, then there is a difference. No matter what difference you noticed, if you notice a difference and the p-value is significant, then that difference actually exists. If the p-value is not significant, then that difference might have occurred by chance. It does not mean that that difference does not exist. And it's because it might have occurred by chance that you still think, if it's important, you still say, hey, this is clinically significant, so we need to pay attention to this.
All right, thank you so much.
And this is the reason why a lot of journals are saying, hey, please, we don't want you to report values with p-values, because a lot of times, a lot of folks have taken a p-value that's not statistically significant to say there's no difference. And as a result, they've thrown away a lot of good research. And which is one of the reasons, it's equally one of the reasons why a lot of research has not gotten published, because people are like, oh, nothing is statistically significant in that. No. So please be mindful, be careful, always interpret based on the clinical information that you have. Let's put it this way, okay? Say you are the patient, or one of your family member is a patient, and you have to receive a treatment, okay? And what we saw there for the clinically significant was 0.5 something. I don't have the article. Well, let's just say 0.57 to like 14 point something. Okay. So what that means is, remember the event. The event was stroke. Was stroke happening? The event of stroke happening. And we're saying that this value, although it was 0.7, that on a really good day, it could be as little as 0.5 for the incidence rate. And on a really bad day, it could be as high as 14. Okay, it could be as high as 14. That is a lot. For one person to consider as a risk, that is a lot. Or another way that you can put it, imagine someone telling you, hey, I can operate on you, you know, and the complication rate could be anywhere between 0.5%, okay, to like 140%. That is a very large confidence interval to take into consideration. You know, 0.5%, you'll probably be like, hey, yeah, I can go with this. For 140%, you know, it's like, dude, I don't think this is going to work. Okay. So some patients might be like, okay, I don't worry because I think, you know, I'm positive, I'm optimistic. I think I will lie in the 0.5. And some other patients will be like, just the fact that you said 140, I don't like this idea. But you have to tell them and let them choose, right? Okay, so
yes.
So let's move forward with this. So I really like this study for one of these aspects that it's bringing, the time to event. Like we said, right? We said, okay, we know an event. We define an event as primary outcome, stroke, hemorrhagic stroke, ischemic stroke. Okay, and then we said event. We're going to say, did it happen? And we're going to say when it happened. So what happens then is we can draw what we call a Kaplan-Meier curve. I think some of you have seen it. I'm on my phone, so I can't share videos of it, photos of it. If any of you goes on the internet, if you don't know about it, just go and share, just go and search for Kaplan-Meier curve. It's usually used for survival, usually like in oncology, neuro-oncology, all kinds of oncology. But you don't only use it for oncology. Whenever you have an event that happens within time, you can use a time to event curve. And one of them is the Kaplan-Meier curve. It's written Kaplan. Kaplan. Meier is Meier. Kaplan-Meier curve. So what you will see is like a step looking curve. Usually it starts from the top and then it's like going down, but it can go the other way around where it starts from the bottom and it's going up. So if you're looking at a Kaplan-Meier curve, it starts usually at the top at 100%. So we have 100% of the population. And whenever an event happens, it goes down a step in such a way that if the vertical portion of the step is very long, then you know that a lot of events happen at that point. Here, our event were strokes. So if your Kaplan-Meier curve looks kind of horizontal, it's not you don't have those big vertical things like the first 10 days, you're like, oh, okay, this means that during the first 10 days, we don't have a lot of events of stroke. But then if on day 10, all of a sudden you have a drop in like 25% of the curve, that is like, oh my goodness, day 10 is a day that we need to be very careful because a lot of these events happen around day 10. Okay, so when you look at the results of this paper, pay attention to the curves. Pay attention to the curves. Pay attention, try and read them based on that, and then see how they compare the groups. Check the two groups. Are they really, is there one that's really above the other one? Do they cross at any point? So if they're crossing, then it means that at that point where it crosses, you know, one treatment becomes better than the other one. So that again, it's interesting. Another thing that you want to know is when you do a Kaplan-Meier curve, it's an adjusted analysis. What that means is you've not taken into account, hey, could something other than just giving the treatment explain this? So to take that into those items into consideration, those elements, what you can do is you can say, hey, how about we analyze this based on other subgroups? And one of them could be, so let me just put this question out there. What do you think in this population of patients, look at all the information you were given, what can explain that some patients have strokes besides receiving aspirin and clopidogrel or aspirin alone? What else? What risk factors do you know that can explain a stroke event?
So possibly age and hypertension, presence of hypertension.
Thank you so much. Great. And there's a lot of them, right? So one of the advantages of doing a randomized control trial, like we said before, is that if you've truly randomized, what you will notice is our group A. Remember, we said group A was aspirin alone. Group B would be aspirin plus clopidogrel. Then if you went into those two populations, usually table 1. If you look at table 1 and you're looking at, what is the mean age and maybe standard deviation of the age in this group, it should be approximately the same. If there was true randomization, they should be about the same. Like you said, hypertension, was there a group that had higher blood pressure values or uncontrolled blood pressure? If there's one of those groups, then maybe there was not a good randomization. So when you're looking at table 1, try and look at those two groups when they were compared. Are there certain things that were different there? Now, other things that you can take into consideration is equally maybe the type of stroke they had before. So there's a lot of things. Okay, that's why you need clinical. You need to know the disease. You need to have known that, hey, when we're talking about strokes, this is what is interesting. This is what can affect this. So now what you would do is, because the Kaplan-Meier curve alone is an unadjusted curve or analysis, now you can do an analysis taking into consideration the other factors that Gideon, for example, mentioned, and it's on many of them. That is when we start speaking of the Cox regression. So if you look at the Cox regression in that paper, I hope you have the paper in front of you. In the Cox regression, what you will see is that they started integrating other stuff. They didn't just say event and then time. They started saying, okay, events, yes. They said time, yes. And then they started adding other stuff. They said, oh, what about the status at this point? And then they put those elements into them. And then they try to find out if some of those elements will explain that. So that is how you get that regression. Okay, so you go into a Cox regression. And remember, Cox regression is only the regression for time to event. If you're looking at a regression only for binomial, you will look for a binomial regression. If you're looking for a regression for events that happen daily, it'll be a Poisson regression. If you're looking for a regression for an outcome that is continuous, then you will use a linear regression model. All of those are different regressions, but you choose them based on the type of data that you have. Once again, to say it, if our outcome was not just, is there a stroke, yes or no? Okay, yes or no. If we just stayed there and we didn't say we want to know yes or no, but yes or no on day 1, yes or no on day 2. When you say day something, then you're going into time to event. If all we said was how many strokes were there during the first 90 days, full stop, then we will have used a binomial regression. If we had said, what was the blood pressure of the patients during their treatment? Blood pressure is a continuous value, so they would have a lot of blood pressure values as a result. So then we'll use a linear regression model. Okay, I hope it's simple to understand. And once again, I've said all these things in the previous video. Go back to the AFAN YouTube channel and then check the first video we had on research. We said all these things. Okay, I guess there's no question. So I've spoken a lot. How about we do this? Oh no! Before we go, I would be sorry if I didn't tell you about this. When we talk about a randomized control trial, remember I said when you have two groups, right? The two groups should be as much as possible, equal as much as possible. They're not always equal, but they're always close. So when we do that, unfortunately, one of the things that happens is the patients don't always complete the treatment. The patients don't always finish the study. Why? A patient might immigrate out of where you are. A patient might decide not to participate anymore. It's their choice anyway. You can't force a patient to complete your study. Now imagine that in one group A, for example, 10% of the patients didn't complete the study. And you don't see them anymore. And imagine that these 10 patients have left the study and they go on to have the event, which is a stroke. Now, because you didn't follow them up, if you calculate the events in your population without these patients, excluding these patients because they left the study, then what will happen is you will get an impression that those in group A had a better prognosis because, you know, the 10% that left the study weren't taken into consideration. Okay, so you cannot, when you're doing an RCT, just forget about patients because, you know, they disappeared. You can't do that. Okay, so to take into consideration that they might leave, we do what we call an ITT, intention to treat analysis. Intention to treat. So you use the data as though they were still in that group. You can make it very simple, but we're just acting as though they were still in the study. That's how I can put it, so I don't take much time. So I'll invite each and every one of you to read this concepts, intention to treat. And so when you're doing an RCT, always check how many patients dropped out. Why did they drop out? And what did the authors do about the analysis? Did they use an intention to treat analysis? So always ask that question. And it's very important, okay? And it's the same way we say in surgery that a good surgeon or great outcomes are only due to the fact that patients were not followed up. If you're looking at someone who's operated on patients and they only show you the day one outcomes, you will think they're the best surgeon in the world. But if you waited 10 years to see their patients generally, then you find out that maybe that one patient you thought had a great outcome went on to die, 2 weeks after their discharge. That is to say that you as neurosurgeons should always follow your patients. The father of modern neurosurgery is known for following his patients, Harvey Cushing. He, till today, at Brigham Women's Hospital, where he started, the first department of neurosurgery, people still have access to patient files, still have access to his patients' files because he was following his patients for years and years, all his Cushing patients, everything. So you have to do that. And in the same vein, if you're doing a study, you need to try as much as possible to keep in touch with your patients. If you lose them, you need to do an analysis as though they were still in the study. That is called an intention to treat analysis. Is there a question? So here's a question by CBMJ. Patients in dual antiplatelet group were treated with aspirin and clopidogrel for the first 21 days, and then clopidogrel alone on days 22 through 90. Meanwhile, patients in the mono antiplatelet group were treated with placebo and aspirin for 90 days. Why was aspirin aborted at day 21 to continue? This here is, I would actually give you this as I think you should present on this. I think you should definitely present on this, on the prevention of strokes, the role of aspirin and clopidogrel, the pathophysiology, and their use, the recommendations today. I think that would be a great topic, and everyone would profit from it. So now that we have this information, I think let's discuss the results. I've spoken quite a lot. So let's discuss the result. I will open mic. I'll shut up for the next minutes because I've spoken a lot. Yes, we're listening.
Okay. I don't have the article in front of me. I think, or if I can remember, I think there was no statistical difference between the use of clopidogrel associated with aspirin and aspirin alone in both groups of patients. So that was they were just I think their results were different from what Chance had and what I don't remember. I think there were two other studies who carried out the same kind of studies, though not for the same reasons, but amongst which Chance carried out. But I think it was there was a difference. They didn't find a statistical difference in the use of both groups. Now, one of the reasons why they said maybe they didn't find this difference was the fact that they took only 45 centers as sample compared to Chance, who took 119 centers, if I'm not mistaken.
Yeah, thank you so much, Dr. Natalie. Anyone else? Anyone else? That's a very good summary of the primary outcome. Remember that there were secondary outcomes. I know we didn't mention them. I think they were evaluating the interaction and the safety profile. And anyone care to tell us what they defined as the safety here? Right. So this is why CBMJ's presentation will be very interesting. Bleeding events were defined as a safety, and they were not meant to be. They weren't found to be statistically significant. But once again, don't just hang your hat on the p-value. Just go ahead, look at the hazard ratio when it's given to you, and then look at the confidence interval when you're interpreting those values. So very, 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 very good example here. I really like this because I think this is one opportunity for our members to get into more sophisticated research. As a group, we've done a lot of research, yes, but there's a lot of room for us to get into more of this kind of research. And I'm counting on each and every one of you to keep attending these sessions, keep reading, keep learning, so that we can come up with more complex, this kind of level of research. It's definitely possible. Don't think it's not possible. And I think I've said it before, but please always read the articles before you come. If you do it, then it's much easier. Yes, you feel like you don't understand everything, but then you're able to ask a question and we're able to answer them. I know that we've not been able to talk or cover everything on this article, but we try to get on this really nitty-gritty stuff to make sure that it's more palatable, I would say. So my advice to each and every one of you, even if you've read it, find some time and reread the article with what we've spoken about today. If you have any questions, ask them in the group. Let's talk about it and make sure everyone is on the same page. Another thing that was really interesting here was classification of evidence. For that, I'll ask everyone to read on the grade, classification for scientific or medical evidence. How do they come about to say, this is a class 2? What does class 2 mean? What does class 1 mean as a level of evidence? And what are the implications for the study? And if you have more time, reading about the other forms of all the other trials that is mentioned in the paper will be good. I'd like to apologize for the fact that we didn't respect the day exactly. I mean, this month we had some great speakers. They were available when we wanted to have our journal club, so we had to reschedule. But from next month, we'll make sure that doesn't happen. Thank you all for attending. It's been more than an hour, so I understand that we might be tired, and I know we've given a lot of statistics here. Again, please go to the YouTube AFAN page channel. Check that video we had at the beginning about methodology. Watch it. You'll find that we had a lot of slides explaining everything. So if there's anything you felt that was too complicated today, I promise if you go and watch that video, you will feel a lot less confused about what we were saying today. So looking forward to the next session and looking forward to see all of you contribute and participate in this kind of studies. Thank you so much.